A few comments here. Like most, I'm a victim of confirmation bias, and I'm going to share some of that with you. Some will be a bit more cynical, but it is because of the context in which I present and the environment in which I live. And 20 years ago, I was lucky enough to write an article about compensation plans before I knew anything about business. And human behavior is human behavior, and it very much is in agreement with what Susanna presented. And so our motivators don't change. So I'm going to talk about surgeon-related drivers of hospital costs. I'm going to show you some data based on work we've done with Avantgarde Health, and then use that in context of the world in which I work and what's already been presented and some of the resistance that I've seen to implementing these changes. Now, this was a symposium we had at the American Academy of Orthopedic Surgeons, which was organized by Steve Schutzer, and Porter was involved. And so Porter and I will be effectively presenting some of what we presented here. This was the first day of the Academy, and we had, I don't know, maybe 20 people in the audience. So it gives us an opportunity to share some of what we did here. But the title of it was Co-Management Gain Sharing is a Juice Worth the Squeeze. And so let me proceed on. I have some conflicts here, which are mainly my relationship with Avantgarde Health. So my focus here was to look at what are the drivers of surgical costs to hospitals and ASCs, to what extent do orthopedic surgeons' decisions affect the overall hospital costs, and what are the pros and cons of gain sharing? You've already heard a lot of the pros. It's hard to find the cons. However, the organization in which I work seems to find them. Now, everybody's familiar with Peter Drucker's statement, culture eats strategy for breakfast. So that's very important because everything we do is in context of where we do it. And certain areas are more fertile than others for change. And I actually prefer the quote attributed to Al Capone, who was the gangster in Chicago. He said, "You're either at the table or on the menu." And again, Susanna showed you a slide that could kind of go along with this. So my way of looking at this in terms of alignment is that this is more of a complicated tug of war. And if you're like me, you may feel you're pulling in one direction and others are pulling in opposite directions. And this just reflects the friction we have in the system to align. So if we look at all these players here, and there are more than what Susanna showed you, let's start with the patient, first of all, who wants an outcome that's durable. We'll get to why durable is important. You, of course, you want a good outcome for your patient, but you want an income. Then the government is focused on reducing cost and controlling. The insurance companies are looking for lower cost and a profit. The implant companies have a fiduciary responsibility to shareholders, and so they want quality, market share, and profit, because there are sometimes conflicts related to our relationships with these players as well. And then, of course, the hospital wants cost containment. And that's not just made up. In the top 5 priorities that our CEO talked about, that was item number 5 on the list, cost containment. Quality didn't appear there. So if we look at the definition of value according to Porter and Herzlinger and others, you have to remember there's a numerator and a denominator. And we have to look at outcome over a temporal frame of reference. So over time is really important to understand who captures the value. And if the episode of care is shorter, it's very different than if it's longer. And it depends not only on that, but also in the denominator, what do you measure and how do you measure it? What's your accounting methodology? And these accounting methodologies, I believe, can vary depending on which institution you're looking at, or even which part of the institution, because I believe our outpatient surgery centers, it lends itself to an accounting methodology for TDABC that we could do, but it's much harder to do that in the main hospital setting. So if we look at the adoption curve of innovation and we look at the different players here, this is just my opinion, but where you fall on the adoption curve may be quite relevant. And I don't know if what Hans presented puts him more to the left or not, but it feels like that. But where I work feels more like I'm to the right. And understandably, large academic medical centers tend to be risk averse and move much slower to adopting any new approach, be it some kind of a compensation plan change, than others do. And this is very much evident because when you look at many of our colleagues out there who work in different settings, compensation is very important from the standpoint of what you can do within a system. So whether you're academic straight salary or fee for service, or you have an RVU model, or you're private-demic with some kind of hybrid with ownership, or maybe you're a private group or private equity is involved, or you're a large not-for-profit, et cetera. These are different contexts for what you may or may not be able to accomplish in your organization. And each of these has really different approaches. This is a really interesting article that was sent to me. I think Derek might have sent this to me. It's entitled, "Why is it so hard for academic medical centers to succeed in value-based care?" I think it's worth reading here. Academic medical centers excel in many ways, but struggle to succeed at delivering cost-effective care in value-based payment models. And much of the underperformance in places like where I work are principally due to two core competencies that are lacking. Number one, there's a limited ability to redesign clinical workflows. This is absolutely the case, I can tell you, after 27 years working at a Maine hospital. And the inability or unwillingness to change the economic relationships with specialists. Now, interestingly, as our organization is becoming a new entity called Mass General Brigham, the compensation plan is changing. And I don't think we have time to talk about that here, but certainly it's changing, but maybe more to one side of the graph that Susanna showed than others. The key factors that play a role here are the electronic medical records that lock in existing work patterns, the compensation systems that reward volume over value, the organizational structure that is problematic for change management, and complex and somewhat poor accounting systems that are difficult to analyze. So Evan O'Donnell did a nice study in collaboration with Avant-Garde using their automated approach, just looking at the cost drivers in a very commonly performed procedure, rotator cuff repairs. And over 600 procedures were evaluated by 13 physicians who were shoulder or sports surgeons at our two academic medical centers. And we measured cost using TD-ABC measurement techniques. And what we found was that the cost varied by 6x. Intraoperative costs were 91% of the entire episode from pre-op to post-op. The major cost drivers were biological adjuncts and surgeon preference that was idiosyncratic. While there were additional cost drivers of tendon retraction and fatty atrophy and these kinds of things that orthopedic surgeons will know what I'm talking about, they weren't the major drivers. And not associated with cost was the patient age or comorbidities, or actually the number of tendons that were torn that needed to be repaired. And this is a nice target that demonstrates for you the outliers in terms of overall cost for the 624 patients. And you can see the high-cost patients are clearly identified in this graphic. And what I don't have for you is actual margin effect, which you can imagine who's losing money and who's making money and what the opportunities are that exist here if you scale this over the entire book of business that the organization does. It's an opportunity. Now, if you wonder, where is this sort of thing possible? If you look at the University of Utah, they have a program called UP, which basically is the hospital acting as a VC for departments, including orthopedics, that create cost-effective solutions. And they share in a co-management model with the department. They do so not so much for physician revenue, but for resources returned to the department to fulfill the mission. And for me, that's a major problem at our institution. We have a lot of mandates without the resources to accomplish these mandates, and this would be one way certainly to be able to solve that problem. The other thing I was interested in is what's the size of the book of business of orthopedics? And at our institution, if you look at outpatient and inpatient, just over 1 month here, we constituted 26% of all of the procedures done, and clearly that was the largest of all of the departments. Now, the problem is, like most academic departments, there is a shortfall here, and you can see in blue is the cash from operations, and in the red is the operating expenses. And every year, magically, it seems that things zero out. But why is it that we have it like this? And the reason is we're using a model that simply doesn't work. Lately, as you know, after the pandemic came on into play, and this was a study that we did in collaboration with Avant-Garde, we started doing outpatient arthroplasty. The CMS approved this, and you can see by quarter the growth, significant growth. And we published on this and did a review of the safety. It's significant safety and significant cost savings. And actually, what's interesting is if you look at the CMS reimbursement from 2020 to 2021, what's interesting to see is that the outpatient reimbursement for shoulder arthroplasty went up, admittedly significantly lower than the inpatient, but the reimbursement to physicians went down. And this is overall not necessarily reflective of what we're getting paid at our institution, but nonetheless, this is again a inconsistency that may play a role in what Susanna presented in terms of burnout. I want to further than this, and I wanted to look at our outpatient experience and how efficient we were in the outpatient center versus the main hospital. And for this, I had advisors from Harvard Business School when I was there, including someone who is an expert in forensic accounting. And so when we looked at everything that we did by body part and specialty, by volume, the largest contributor was the hand service because they did high volume, rapid cases, et cetera. But when we looked at RVUs in terms of the major RVUs and using that as a surrogate for actual payments, it was actually the shoulder service that contributed the largest book of business. Now, that's important to understand because in our system for a period of time, we had a different payment scale in the outpatient center versus the main hospital. And so where you distribute your cases and do them may actually result in different payments for service. And that's worthwhile considering when you allocate resources and capacity for different services. Now, when we looked at the overall numbers here, and of course I redacted this, what was interesting to see in the outpatient center is the average profit over the time period that we reviewed this was 38%, which is quite remarkable. And that's without any kind of co-management and gain sharing. And the average per case profit was 38% as well. What's interesting is if we drill down into two areas in sports medicine, let's say ACL surgery, you can see that the case here in green, physician E, is the most cost effective, and that individual did 83 cases. But the least cost effective was a total of 2.3x higher for the same procedure. So that's an opportunity waiting to be explored from the standpoint of effect on the bottom line. It's even worse in rotator cuff repair, and this was actually worse than what O'Donnell published. You can see that the variation by surgeon here, each of these letters is a surgeon, of course, is almost 8x. Again, that is a tremendous opportunity that's going by the wayside that could be addressed. If we look at key performance indicators, it's very easy to look at these numbers here. And for example, look at percent of time as turnover in the main hospital, which you can see on the upper line, and then in our outpatient surgery center in orthopedics. And then you can compare us to the other services, and the percent time block time utilization has to do with capacity management, and that's another opportunity that we could influence. And if you look here again at on-time case starts and turnover in terms of time in each of these centers, you know immediately which is the most efficient. The question is, why can't we change in other centers? What are the barriers to this? And it seems to me that alignment would be one way to move in the right direction here. So at the end of the day, in my way of thinking, it's simply about the carrot or the stick. And for the most part, I feel that the carrot existed more in the outpatient center when we started that, and the stick has remained more the case of motivation in our hospital facility. Thank you.